Welcome, everybody. We're so glad that you're here. Thank you very much for joining us. We are delighted that you could make the presentation today. We're going to talk about the geriatric giants, and that is dementia, delirium, and depression. And so today's topic covers three separate issues, but they're often mistaken for each other. And all three conditions can cause confusion and memory loss. And because they look so similar, it's sometimes hard to sort out at first glance what's really going on. So we're going to compare and contrast the geriatric giants, these three: dementia, delirium, and depression. So let's start by just talking about aging a little bit. Aging changes our mental abilities. Sometimes a little lower adaptability, slower response to stimuli, might have sleep pattern disturbances, decreased short-term memory. That's pretty standard. That's not dementia. That's just what happens as we age. Our brains become a little more frail. And so depression and delirium cause more of a disturbance in mental functioning than they would if they occurred in a younger person. So differentiating between delirium, depression, and dementia is really, really important. So let's start with dementia. It's the loss of thinking ability, memory, or other intellectual capabilities. It affects your everyday life. Dementia actually is not a disease. Dementia is not a disease in and of itself. It's a syndrome, or a collection of symptoms that may be caused by a wide variety of different diseases and conditions. And when you read the literature, the scientists can't agree on how many different causes there are, anywhere from 70 to 200 different diseases that cause dementia. There's always an underlying disease process affecting the brain for dementia to happen. So as I just said, dementia is not a disease itself, and it's not a normal part of aging. I want to reassure you about that. But it is the name that they give for this group of symptoms, and it includes progressive loss in memory, judgment, reasoning, ability to communicate, ability to function, and it includes changes in mood and behavior. So when we're talking about dementia, we know that it's not a disease. We know that it's symptoms that can accompany a wide variety of diseases. And what I'm going to do now is I'm just going to look at some of the different diseases that cause dementia. And these are the diseases that the Alzheimer's Society is here to support folks through. If any type of dementia happens in your life, the Alzheimer's Society is the place to go, even if it's not Alzheimer's dementia. But let's start there. Let's start with Alzheimer's. So they have a red umbrella on the screen because dementia is considered an umbrella term. And this umbrella term, dementia, includes all that laundry list of symptoms I gave you. And the most common cause is Alzheimer's disease. So you could say that Alzheimer's is the most common type of dementia that there is. There's also quite a few diseases that fall under the frontotemporal rib of the umbrella. And so when you have anything, we call it FTD for short, when you have anything in the FTD family, it doesn't start with memory loss like Alzheimer's tends to start with. It starts with changes in language, in judgment, reasoning, and behavior. And it's actually quite rare. The FTDs are considered quite rare. Alzheimer's, really common, very common. Then there's something called Lewy body dementia, and it looks like a cross between Alzheimer's and Parkinson's. People have fluctuations in their cognition. They have Parkinsonian symptoms, rigidity, slowness of movement, shuffling gait, potentially tremors. It's hallmarked by visual and quite vivid visual hallucinations. And Lewy body affects more men than women. Alzheimer's affects more women than men. There are differences between the dementias, but we're still the go-to place for any of them. And then the second most common type of dementia is vascular dementia. And vascular dementia can occur because somebody's had a major stroke, or it can occur cumulatively from a series of transient ischemic attacks. Sometimes they're called mini strokes. They used to call it multi-infarct dementia years ago. Any vascular issues, white matter disease, blood vessel disease, that can cause a vascular dementia. And when we talk about mixed dementia, we're really talking about when somebody, unfortunately, has more than one type of dementia at a time. And the most common mix is Alzheimer's disease and vascular, but you can have Alzheimer's and Lewy body at the same time. So just want you to know that there are many types of dementia. You never develop dementia unless there's an underlying disease process that drives it. Now, I've said there are many types of dementia. The good news is that some are reversible. So the ones that are under that red umbrella that we just looked at, not so good. Those are irreversible dementias. But I'm going to give you some examples of when people might look really confused. They might have trouble with memory. They might have trouble concentrating. And they're worried. They don't want to go to the doc because they don't want to hear that it's a form of dementia. But it's something that is acute and reversible. It's something that can be treated. So you always want to go, if you're having cognitive changes, you want to get these things checked for sure. So here are some things that they used to call it pseudo-dementia. It kind of can mimic dementia. Atypical depression can look like dementia. When it comes to medications, there could be medication interactions, there could be toxicity, it could be sedatives, it could be nutritional disorders, diabetes, dehydration, vitamin deficiency, impaction, constipation. All those things, believe it or not, make a big difference to your mental well-being. Metabolic disorders, maybe you have undiagnosed thyroid disease. It can be infections. If your body is trying to fight a UTI or a urinary tract infection or pneumonia, or maybe oral infection, something like that, you can look really confused. It could be due to tumors or something called normal pressure hydrocephalus. These are all things that you want to get checked on. So enough about dementia. Let's move to delirium for a moment. Delirium is a disturbance of consciousness with reduced ability to focus, sustain, and shift attention. It is an acute organic mental disorder. It's characterized by confusion, disorientation, restlessness, clouding of the consciousness, incoherence, fear, anxiety, excitement, illusions, hallucinations, and/or delusions. Wow, that's a laundry list. We're going to take that apart for you. And it's an acute onset. In other words, it's sudden onset, and it has a fluctuating course. So let's look at that in a little more detail. So delirium is a sudden change. There's sudden onset of confusion that often fluctuates within 24 hours. There is a sudden decline in functioning. There are new difficulties with communication. Tends to be worse at night. People may have visual hallucinations. That doesn't mean they have Lewy body dementia. They may be disoriented. They may have difficulty focusing or concentrating. And always, delirium is considered a medical emergency. You really want to get support for delirium ASAP. So when it comes to recognizing delirium, studies have documented that 32 to 66% of delirium cases were unrecognized by physicians caring for patients because it's often been mistaken for dementia or depression or normal changes of aging. And yet it's not. It's a thing unto itself. So here's, I'm going to show you a little clip. This is a movie called It's Not My Mom. When I sent you the slides, This is a live link. You can click on this link and you can watch this movie over again, or you could share it with somebody else. Oh, I've just got to admit somebody now. Sorry, admit. Okay, there we go. So I'll just start the movie now. Oh, because I admitted my mouse is gone. Wait a minute. That was supposed to play. Well, isn't that interesting? It played for me this morning. I think the same. Okay, well, I've got it.
I want to leave.
I'm just going to switch. I'm going to pause the share. I'm going to bring up a new share. I'm going to bring up the movie for you. And here we go.
I want to leave right now.
You can't
right
leave.
now. Where's Mary? I want Mary. But Mary's right there.
Mary's not here. It's just me. Calm
Right
down.
there. I want to leave.
You
I
can't.
want to leave right now. Right now.
I've got to see the doctor.
Hi, Mrs. Andrews. Your mother has had dementia for some time now. Things just are not improving. Maybe we should be thinking about a nursing home.
I know she's had dementia, but she wasn't like this 2 days ago. This is not my mom.
Doctors and nurses often miss the diagnosis of delirium in older people and may think the confusion is due to dementia. Delirium is not dementia. It
I
comes on
just
quickly
realized
and
that
is
it's not
treatable.
showing for you.
Doctors and
I'm
nurses
sorry.
need to
I
ask families,
apologize.
Is this a change? For more
So-
information on delirium, please go to thisisnotmymom.ca.
I'm going to figure out what went wrong there. My sincere apologies to you folks. That was not a good thing at all. Okay, let's get back here and see what we can do with our screen share, because that was not the plan. Okay, screen share. Let's back this up. Oops, this up. Okay, this should work this time.
I want to leave.
You
I
can't
want
leave.
to
You
leave
can't-
right now.
you can't
right
leave.
now. Where's Mary? I want Mary. But Mary's right there.
Mary's not here. It's just
She
me.
is. She's
Calm
right
down.
there. I want to leave.
You
I
can't.
want to leave right now. Right now.
We've got to see the doctor.
Oh.
Hi, Mrs. Andrews. Your mother has had dementia for some time now. Things just are not improving. Maybe we should be thinking about a nursing home.
I know she's had dementia, but she wasn't like this 2 days ago. This is not my mom.
Doctors and nurses often miss the diagnosis of delirium in older people and may think the confusion is due to dementia. Delirium is not dementia. It comes on quickly and is treatable. Doctors and nurses need to ask families, is this a change? For more information on delirium, please go to thisisnotmymom.ca.
Okay, let's go back to the slides. Let's resume.
Today I'm going to reveal 2 types of protein
Oh,
that make your
now what's
arthritis
playing?
worse. If you have arthritis,
need to see this.
I tell you, folks, it's because I'm taping.
Co-founder of the Pain Arthritis Relief Center here
The
in Rockville.
Pixies are
My team and I,
definitely
tens of
after
thousands.
me. We do not need to hear about that. Let's get back here. Let's see what we can do. Let's see if we can make this work. Okay. Screen share. I hope you're seeing the slides now. I sincerely apologize for that. You've seen the little movie clip, This Is Not My Mom. You get the idea that it was sudden. As the daughter said, she wasn't like this 2 days ago, and there was nothing she could say to help calm her mom. Okay, so let us move on. So delirium is a health emergency. The underlying cause of the delirium needs to be found and treated to prevent permanent disability. People with Alzheimer's disease or other dementias can also develop a delirium, which will temporarily make their dementia worse until the underlying medical emergency is resolved. So unless delirium is caused by a stroke, it is usual to have it disappear once the underlying issue, the medical emergency, is resolved. So something causes the delirium, perhaps an infection, makes the dementia look worse, and it's very hard for the healthcare providers to decide exactly what's going on. And that's where you need to be an advocate to be able to speak up and say, no, this is not my person's normal. Even though they have dementia, This is not their normal. So just want to say for younger adults, it takes something like sunstroke or recovery from anesthetic to cause delirium. It doesn't, it's not easily caused in a younger person. But delirium can be a dramatic change. People who have been immobile, confused, incontinent can return to normal when a medication is changed or an infection is treated. And people may have been just fine. They may have been out shopping. They may have been A-okay a few days before. So it's the history, it's the suddenness of the onset that makes the difference. And that's why it's impossible that it's a worsening of dementia, because it's so sudden. Dementia is very slow. Let's see. Oh, this one decided to work. Good.
Hi, my name is Tracy Van Beek and I'm the inpatient therapy lead at the Royal Free London Hampstead site. I'd like to tell you about the two types of delirium that you might see. The first is hyperactive delirium, and in these people you might see a heightened sense of arousal. People might be very restless, agitated, or in some cases even aggressive. The other is hypoactive delirium, and in these patients they might become very withdrawn, quiet, or sleepy. This delirium is harder to recognize and in some cases has poor outcomes.
All right, some other features of delirium, they're subtypes. So the nurse was just explaining it can go in either direction. Hyperactive, the ones who get noticed, that's what the first film clip was like, right? The woman who wanted Mary right away and didn't want to stay, hyperactive. And the hypo means to slow down. So the ones who behave, who basically are very quiet and they just sit there and they might even look like they're asleep the whole time. Or just to complicate it, you can fluctuate between the two. It can be a mixture. So features in delirium include an altered sleep-wake cycle from what's normal for folks. Labial emotions, in other words, very extreme emotions. You saw that in the woman on the stretcher. It could be fear, anger, euphoria, depression, anxiety. Also, psychosis is pretty common. Delusions of persecution. The nurse is poisoning me, classic example. Or people having hallucinations. And the thing is, these can be visual hallucinations where they're seeing something that has no basis in reality and nobody else is seeing, or they could be auditory where they hear something that nobody else hears, or tactile, they could feel like there's bugs crawling on them or something like that, or threatening, that's that persecution piece. And they're very poorly articulated. They can't really explain what's going on, and it can fluctuate, and that makes it tricky. So let's look side by side, delirium versus dementia. So with delirium, it develops over a few hours or maybe a few days, very sudden. Dementia, on the other hand, very gradual. You become aware of it over months or years that something wrong. And the only time that would be different is with a stroke. So delirium indicates a sudden and a really serious change in medical condition, and it requires investigation right away. But dementia, considered chronic, progressive, it is a fatal illness, and it requires assessment and treatment. And then delirium versus dementia. Delirium, full recovery when treatment is given. Dementia, with the irreversible dementias, it causes shrinkage and death of the brain cells, the neurons, the nerve brains. And once these are gone, the functions and memories that they perform, they also disappear. So you can see side by side, they're very, very different. So possible causes of delirium, medication toxicity. Even if you're taking meds the way you were instructed, over time, as we age, our bodies don't metabolize as efficiently, and you can get a toxic buildup of medication, or you might be taking something new. It might throw you off, or it might be an interaction of a medication from an over-the-counter med with a prescription med. There are many possibilities there. Nutritional disorders that can certainly play a part, or metabolic disorders. If you have high or low blood sugar, if your diabetes isn't under control, or if you have super low oxygen levels, if you're dehydrated, we all need to push fluids. I'll do some right now. Any undetected infection. If people have surgery, the strain of the surgery and the anesthetic can cause a delirium. And normal pressure hydrocephalus, that's when there is a buildup of cerebral spinal fluid around the brain. That can cause a delirium as well. So basically drugs and bugs. So risk factors, you're at a higher risk of developing delirium if you have some sort of cognitive impairment. So if you're already living with dementia, your risk of developing delirium is higher. The older you are, the higher your risk. Any sort of sensory disturbance, if you can't hear, can't see, you've lost your hearing aids, your glasses got crushed, immobilization, being bedridden, any severe illness, any psychoactive medication use, any sleep deprivation. Yeah, that can lead to worsening of function, and can lead, if it's long enough, to delirium. And dehydration, that comes up again. So how do you manage delirium? Okay, well, you want to address any risk factors. So you want to make sure people have functioning glasses and hearing aids, and they drink, stay hydrated. You look into infections. You want to treat pain. Pain has a personality all its own, and you want to make sure that people aren't in pain. You want to maintain fluid balance and nutrition. Definitely avoid constipation. Minimize medication use wherever possible. You want to maximize sensory clues. You want to keep calendars around. You want to have the windows open during the day and the curtains wide, so they're not sitting in a dark room when it's really a sunny day. You want to avoid sleep deprivation, restraints, and immobilization. If people can't move, that is definitely a contributing factor. The CAM, that's short for Confused Assessment Method. The CAM is what clinicians use to diagnose delirium. And this is how it works. You need either 1, 2, and 3 or 4. So you have to have 1 and 2, but either 3 or 4. So acute onset and fluctuating course, have to have that. Inattention, you have to have that. And maybe you also have disorganized thinking and or altered level of consciousness. And that's what the clinicians are going to look for. Because delirium leads to hospitalization, and when you're in hospital, prolonged stays in hospital. Here are some stats for you. Up to 25% of older adults are hospitalized with delirium. Over 50% develop delirium during their hospitalization. 40 to 50% develop delirium after hip surgery, and 70% of older persons in intensive care have delirium. So we really want to understand delirium and work on keeping it in check as much as possible. So here are some figures for delirium in Ontario. These are very recent figures. I was just on a seminar, maybe not even 6 weeks ago now, delivering this information. So delirium occurrence rate in hospitals, wow, 29 to 64%. In palliative care units, 42 to 88%. And in long-term care or post-acute care, you've been in hospital and you're discharged home, about 20 to 22%. And delirium is present in 8 to 17% of older people who present in the emergency department. And delirium, as we mentioned before, it can easily be overlooked in people living with dementia due to overlapping symptoms. And many people have both conditions. In fact, they hard to pin the numbers down. Anywhere from 22 to 89% of people in the community and hospital have both. So older people who are hospitalized and do not develop delirium, they tend to have a shorter time there, shorter stay in hospital. They have a better prognosis if you don't get delirium. They're better able to function independently. They're less likely to require care in a placement in a care facility. They're less likely to develop cognitive decline, and they have a lower mortality rate. So these are important reasons to really watch out for delirium, treat delirium, keep it in check. Now, depression, the final D. So depression is the most common mental health problem in seniors, and it is not a normal part of aging. In seniors, it often goes unrecognized, but obviously it has a significant impact on the person, their family, and the medical system. So identification of depression in seniors is important because treatment is effective in most people. Now, depression, I've just finished saying it's the most common psychiatric disorder in older adults. It's often associated with physical illness. Under the age of 75, it's more common in women, and over the age of 80, it's more common in men. You can be depressed for physical reasons, psychological reasons, due to loss. It could be part and parcel of alcohol or substance abuse. There are many reasons, and somebody might have more than one reason. When we're talking depression in seniors, often there's a tendency not to admit they're depressed because they're afraid that they'll be sent somewhere or locked away. This is a quote from Dr. Willie Malloy, or it seems a sign of weakness. And sometimes physical symptoms mean a misdiagnosed depression. So we want to really look at it carefully. In the younger population, a generation more comfortable talking about feelings, they're not proud, of being depressed, but there's a greater acceptance to discuss mental health concerns. And I hope that that will open an example for everybody if they are feeling depressed to get checked. So what are they looking for? If you're trying to decide if somebody has a clinical depression, you're looking for sleep disturbance. It says interest reduced. Things that you used to enjoy and take pleasure in, you find no pleasure in now. Guilt, not necessarily legitimate guilt, just feelings of guilt. A preoccupation with physical complaints, somatic complaints, lots and lots of them. Definitely reduced energy, really poor concentration and focus, appetite changes. Usually it can go nonstop eating, or it can go reduced, can go either way. Psychomotor retardation and agitation. Those are fancy words. It's like the hypo and the hyper. It's that sometimes people just slow down and don't want to move at all. And sometimes people just can't sit still. And then suicidal ideation. So that's what a clinician is going to run through. It's going to check on all those pieces when they're looking for depression. So the clinical symptoms, what you might recognize, a lack of self-respect, unresolved turmoil or guilt, body preoccupation, particularly with bowels and stomach, painful sadness, pessimism, anything that's not normal behavior for the person. Now, there are several ways to treat depression, and often there's a combination. So medication, supportive education, helping people learn to manage stress, helping them to get support within a group setting. There can be psychotherapy, that can be cognitive therapy, that can be behavioral therapy. So one is more like talk therapy, and the other is more like behavioral interventions for people. And often a combination of all of those is the most effective. So let's look at them side by side by side. let's make sure that we're really clear on what's what. So when it comes to the history of these three geriatric giants, when you're talking depression, it's a recent onset within the last few weeks. Dementia, very insidious, very gradual. It comes on quite literally over years, and delirium, sudden onset. When you're looking at the course of the situation with depression, it's usually reversible, and it tends to be worse in the morning. With dementia, it's chronic, it's slow, it tends to be worse at night. And with delirium, you've got a real fluctuation over your 24-hour period, and it also tends to be worse at night. When you're looking at the cognitive symptoms side by side, depression, lower self-esteem, complaints of reduced memory. With dementia, there's a global decline, focal cognitive deficit. In other words, all over your cognition, there is decline. When you have vascular dementia, you may notice worsening decline in certain areas, depending on where the vascular incident occurred. And then delirium, you have fluctuating alertness and disorganized thinking. Neurologically, with depression, poor abstraction, they really abstract thinking doesn't do well. With dementia, there's no signs really until later in the illness. With delirium, poor attention span, inability to focus. The psychotic features, depression, they may have somatic delusions. They may feel like they smell bad and everybody can smell them. They may be paranoid. With dementia, the delusions tend to be stealing. Somebody is stealing my watch, my purse, my teeth, my whatever, or that my partner is being unfaithful, even if the partner is not being unfaithful or the partner has passed away. And then with delirium, you're looking at vague, non-specific delusions and hallucinations. When it comes to mood, depression, definitely decreased interest in anything. With dementia, the agitation is not related to the mood. And in delirium, hypo and or hyperactive. So people can be really up or people can be flat as a pancake. And then sleep. With depression, you tend to get early morning waking. With dementia, you just tend to get disorientation to time. And with delirium, the sleep-wake pattern, it can be anywhere from disturbed and they don't sleep at all to stuporous. You can't get them to wake up. So that was sort of the comparison between the three geriatric giants. I want you to know that if you have questions about any of them, you can come to the Alzheimer's Society. We have programs and services that we offer at no charge. We are here to help, so please don't hesitate. Counseling, education, social and recreation opportunities. We have a program called Minds in Motion that combines the best of all worlds because it's physical activity along with social and cognitive interaction and during the second half, and it's designed for people living with dementia and their care partners to attend together. We offer that virtually, we offer that in person, and we offer it 6 days a week because there's a Saturday session as well. We have our YouTube channel, we have a resource library, there's support group sessions. So all it takes is a phone call. That's all it takes. This website, findingyourwayontario.ca, is really designed to help care partners and people living with dementia to understand how to stay safe in the community, because getting lost is a very high risk for people who live with dementia. 6 out of 10 people will have what they call a missing incident during their journey. And so this website helps you to know what to do to reduce risk, what to do if an incident happens. It even gives you an ID form to have filled out and ready to go for the police. If you have to call them, if somebody is missing, there are a great wealth of information on the website. And if you would like that information in hard copy instead of on the web, you just be in touch with the office and they can mail that out to you. We have something called EC or Enhancing Care Education programs. They're not offered in a lecture format like today's education is. It's much more interactive. There is a 4-week and an 8-week program. And when I send the evaluation today, I'll send you a little flyer on these programs. They are designed for you to be able to work on the particular issues that might be challenging you during the dementia journey. And so it's very personalized and very practical. And then I just want to thank anybody who has donated to the Alzheimer's Society Waterloo Wellington. We offer our services at no charge because we fundraise so hard. We have to raise 60% of our annual budget. I don't know if you knew that or not, but we have to raise 60% of our budget to be able to say to you that our core services are offered free. So if you ever donated, thank you. If you're ever in a position that you can donate in the future to Waterloo Wellington to keep the money local, thank you very much. And this is our contact information. This is also how you get to our YouTube channel where we have lots of great stuff. This is our website. You can click on that. And then if you scroll to the very bottom of the first page, it'll take you to this icon. And when you click on that, it takes you right to our YouTube page. We've got education on there. We've got recreation on there. We've got exercise on there. We've got a gamut of really good stuff for you. So what I'm going to do is stop the share and I'm going to put one more thing up. So here it is. And we are going to, I sincerely hope you can see that. So this is a handout that I attached and it talks about delirium. And the reason that I like this so much is it's going to give you some great information and it's also going to help you understand what you can do as a care partner if delirium happens and you're interacting with the medical community. It will give you some ideas of what to say and what to do. So it's got good details for you. And I hope that that will be very useful to you in the future. So what I'm going to do now is I'm just going to stop the recording.